So, what is the hyponatremia? In the hyponatremia, the sodium will be very low. Okay, hyponatremia is defined as a serum sodium concentration less than 135 millimole per liter, or level less than 125 millimole per liter is considered severe. Hyponatremia results from a relative excess of body water to sodium. Okay, relative excess body water to the sodium. Clinical features. So the rate of change of sodium is most important than the absolute sodium value. Patient with chronic hyponatremia can be asymptomatic, while patient with sudden drop can be very unwell. Okay, early symptoms as are headache, nausea, vomiting, and general malaise. Headache, nausea, vomiting, and malaise. Later signs are confusion, agitation, and drowsiness. Acute severe hyponatremia leads to seizure, respiratory depression, coma, and death. This is due to swelling of brain cells when water moves from the extracellular to the intracellular compartment because of the difference in the osmolality between the brain and plasma, resulting in cerebral edema and raised intracranial pressure. What happened here? The hyponatremia is the concentration of the sodium less than 135 millimole per liter. A level less than 125 is the severe hyponatremia, and the hyponatremia results from the relative excess of the water to the sodium. What is the clinical features? The clinical feature is the chronic hyponatremia can be asymptomatic, while the patient is having sudden drop, is very unwell. Early symptoms are headache, nausea, vomiting, and the general malaise. Then later sign are these are the early symptoms. Then the later signs are the confusion, agitation, and drowsiness. And acute severe hyponatremia will be having the seizure, respiratory depression, coma, and may lead to death. This is due to swelling of brain cells when the due to the hyponatremia, sodium will be less. Okay, so the swelling of the brain cells when the water moves from the extracellular to the intracellular, because the sodium in the extracellular compartment will be low. Okay, so to compensate this, the water from outside will go to inside of the cells. Okay, to the intracellular compartment because of difference in the osmolality between the brain and the plasma. The brain cell and the plasma, the osmolality will be different. Okay, resulting in cerebral edema and raised intracranial pressure, and this leads to cerebral edema. Okay, edema and raised intracranial pressure and increased intracranial pressure. Okay, the diagnostic approach. What are the diagnostic approach? So drug history, hydration status, plasma osmolality. Okay, diagnostic approach is having uh, drug history. We have to ask the drug history, then hydration status, then the plasma osmolality. Okay, then the urine osmolality. Okay, then urine sodium, thyroid function, assessment of the cortisol reserve. Okay, we have to ask the drug history, then the hydration, what is the hydration of the patient, then plasma osmolality we have to see, then the urine osmolality we have to see, then the urine sodium level, thyroid function, and the assessment of the cortisol reserve. Okay, so in the plasma osmolality, hyponatremia of any cause is associated with the low plasma osmolality. If the plasma osmolality is normal, then the possibility of the pseudo hyponatremia should be considered. This is an artifactual result due to the reduction in plasma caused by marked hyperlipidemia or hyperproteinemia, that is a multiple myeloma. Then if the plasma osmolality is the high, then the possibility of the hyperosmolar hyponatremia should be considered. This may be due to hyperglycemia or the administration of the mannitol amongst other causes, and reflect the shift of water out of the cell into the extracellular fluid in response to the osmotic effect. Okay, so what we have seen in the plasma osmolality, that the hyponatremia of any cause is having the normally having the low plasma osmolality. But if the plasma osmolality uh, is normal, then this may be due to pseudohyponatremia, and this may be seen in the hyperlipidemia, hyperproteinemia, that is seen in the multiple myeloma. Okay, then if the plasma osmolality is high, then the possibility is the hyperosmolar hyponatremia. Okay, and this may be seen in the administration of the mannitol and extracellular fluid in response the shift of the water out of the cell uh, into the extracellular fluid in response to the osmotic effect. Okay, then we will see the urine osmolality. So, in the urine osmolality, once hypotonic, uh, once hypotonic hyponatremia has been confirmed, urine osmolality should be checked. When hypotonic hyponatremia is considered, urine osmolality we have to see low urine osmolality may present or normal urine osmolality may be there. Okay. So what happened in this? So when the osmolality is low in the urine, less than 100, then it may be due to primary polydipsia, inappropriate administration of the IV fluid, and malnutrition, low salt diet. Okay, low urine osmolality may be seen uh, due to uh, primary polydipsia, then inappropriate administration of the IV fluid, and the malnutrition, low salt diet. Then, when the normal urine osmolality greater than 100 millimosmol per kg, it may be seen in the urine sodium less than 30 millimole per liter, and another one is the urinary sodium is greater than 30 milliosmolar per liter. Okay, so when the urinary osmol sodium is less than 30, the patient uh, volemic patient is hypovolemic, true volume depletion, or third space loss. Okay, it's seen in the true volume depletion. Okay, or third space loss, patient is hypovolemic. Okay, patient is hypovolemic. It's seen in the gastrointestinal salt loss, that is the severe diarrhea or vomiting, then the transdermal salt loss, that is sweating or extensive skin burn, then the third space loss in the pancreatitis, bowel obstruction, or the sepsis, and diuretics. Okay, in this condition, the patient is hypovolemic. Okay, guess GI losses like the diarrhea, vomiting, then the transdermal salt loss in the sweating, and the extensive skin burn, and the third space loss in the pancreatitis, bowel obstruction, and the sepsis, and the diuretics. Okay, patient hyper volemic. If the patient is hypervolemic, then in that intravascular depletion in the fluid overloaded state, intravascular depression in fluid overloaded state, in that congestive cardiac failure, then the cirrhosis and the nephrotic syndrome. Congestive cardiac failure may be there, or cirrhosis, or nephrotic syndrome. Okay, congestive CCF, then the cirrhosis. Okay, liver cirrhosis and the nephrotic syndrome. Okay, heart, liver, and the kidney will be affected in the patient with hypervolemic hyponatremia. Then if the urinary sodium is greater than 30 millimole, then patient is euvolemic, normal circulating volume. It is seen in the SIADH, stimulation of the inappropriate diuretic hormone, secretion of the inappropriate antidiuretic hormone, then ACTH deficiency, and severe hypothyroidism. Okay, ACTH deficiency and the severe hypothyroidism. Then patient is hypovolemic, low circulating volume. In that, Addison's disease, cerebral salt wasting, renal salt wasting, and vomiting. Patient is hypovolemic with the sodium is greater than 30. It's seen in the Addison's disease. Then the cerebral salt wasting, renal salt wasting, and the vomiting causes loss of hydrogen ion and the metabolic alkalosis, which is corrected by the renal excretion of the sodium by carb. However, if the individual is using diuretics or other in evidence of kidney disease, all causes should be considered, as can cause low or high urinary sodium concentration. Then, what is the management? So, in the management, treatment is always cause specific, appropriate fluid replacement in patient with the hypovolemic, hyponatremic, with normal saline, typically leads to improvement. Okay, when the patient is hypovolemic, hyponatremia, the normal saline is cause improvement. Then in patient with the hypervolemic, hyponatremia, okay, in that, treatment is underlying condition is indicated. In acute severe hyponatremia with neurologic compromise, the use of the hypertonic saline should be considered, whatever the cause, with the specialist input and care monitoring. And correction should not be too rapid. Correction should not be too rapid, especially in chronic hyponatremia, as this may cause the central pontine myelinolysis. Okay, this meant if we correct the uh, severe hyponatremia so rapidly, then it will cause the central pontine myelinolysis. Okay.